Okay, in this module I'm going to go over laboratory interpretation of the lipid phenotype test for the lab clinical Pearl. And one of the things you should always consider is whenever you see someone who's got an abnormal lipid panel, meaning the cholesterol levels are really high, their LDL levels are high, the triglycerides are really high, you should always consider running a lipid phenotype test. By really high, for example, I mean like a total cholesterol is like 250, 240, LDL is 150 or even higher, triglycerides 800, 1200, something like that. You should definitely run a lipid phenotype test. And the lipid phenotype test is looking for genetic hyperlipoproteinemia. So lipoproteins or basically things like HDL, right, high density lipoprotein, or LDL, low density lipoprotein. And some people have some genetic defects, for example, in the LDL receptors, or another variant of some type of response with the synthesis or production of some of these lipoproteins. And the other times you should consider running a lipid phenotype test, if you ever see a person who's just not responding to interventions to lower their numbers. Now, that could be dietary interventions, it could be nutraceutical interventions, it could even be pharmaceutical interventions. But if they're just not responding very well, you should definitely consider running a lipid phenotype test. So all your major labs do it. This is a sample of one from LabCorp. But basically, what'll happen when you order the lipid phenotype test is it'll tell you their pattern here. So you can see they check. The lipid electrophoresis just separates these lipoproteins and then determines if there's any shifts in any of the spikes. So there's an alpha, pre-beta, beta, and then chylomicron presentations, so you can see what's here. Now here is a normal pattern. So this person didn't have any type of genetic hyperlipoproteinemias compared to this person who had a type 2B. So you can see here the total cholesterol was 201, but their LDL was 141 and not responding to anything. HDL very, very low. So the follow-up was to run this lipid phenotype test. And they'll just tell you the breakdowns, like beta subfractions and pre-beta were increased or decreased. You don't need to worry about that part of the interpretation. Just look to see what the classification type is. Here it's type 2B. The previous one, the classification was normal, that there was no type of hyperlipoproteinemia. Now these are the main types of hyperlipoproteinemia on the left: type 1, type 2A, type 2B, type 3, type 4, and type 5. All right, and then because of these phenotypes, which again is environmental and genetic factors that get expressed, the following lab markers may be elevated. It's like with type 2A's, LDLs can be really, really high, right? Serum cholesterol levels can be high with type 2s, type 3s. Serum triglyceride levels can be really high with type 5s and type 1s. So this is just a basic chart. You can see the most common ones are the type 4s. 45% of the total hyperlipoproteinemias are type 4s. And then type 2B is about 40%, right? Now, when you look at this chart here, it starts to give you more information, and if you're not familiar with these lipoproteinemias. So, for example, type 1s, there's the defect that's causing these elevated levels of lipoproteins is decreased lipoprotein lipase, altered ApoCT protein, LPL lipoprotein inhibitor in the blood. And then with type 2s, you have an LDL receptor deficiency. Type 4s, you have increased VLDL production, decreased elimination. So these are the exact mechanisms that are happening with these. And then for some people that have these hyperlipoproteinemias, like type 2s, they can have the xanthosemias, where they have the little fatty deposits around their eyelids, or arcus sinalis, like there's a little arc around their eyes, or they can have fatty tendons. And then on this chart, it also goes into some of the treatments that seem to work for them. So for example, type 2s, they use bile acid sequestering drugs that help combine bile with bile acids and niacin. These are just the pharmaceutical ones. We can talk about nutraceutical ones in a second here. But some of these won't really respond to drugs very well, not even to nutraceuticals very well. You have to have a combination approach. The most important thing about this test is to determine if there's any increased risk for atherosclerosis, right? Now, if you were able to attend the Carrazzi Institute cardiovascular module we did, we talked about where lipoproteins fit into the development of atherosclerosis. They're one of many variables that play a role. Ultimately, with atherosclerosis, you have injury to the vascular endothelium, and then once the vascular endothelium is injured, then you can have lipoproteins that infiltrate in, and the higher the low-density lipoproteins, the more lipoproteins you have in circulation. The smaller the LDLs, the easier it is to get into injured vascular endotheliums. The most common cause of the vascular endothelium being injured is high blood pressure that damages the inner lining of the blood vessels, the vascular endothelium. So if you have injury to the vascular endothelium and you have high amounts of LDL circulating and then you have small LDL really infiltrating into the injured vascular endothelium, and then you have oxidation, inflammation, starting to activate the process of foam cell development, and you have activation of inflammatory pathways, then you can really set up the stage for atherosclerosis. Now, when you look at these hyperlipid proteinemias, not all of them have increased risk. So, for example, someone has a type 1, they could have really, really high triglyceride levels, but they're not really any risk for atherosclerosis. And then you could have someone who has like a type 4 who may have really high VLDLs impacting total cholesterol. They have moderate risk. And then someone with type 2, A or B, that would have high risk for atherosclerosis. And these are pretty serious. Like once you have someone with type 2 A's and B's, these are no joke. These people die sooner. Their rates of cardiovascular disease, whether it's myocardial infarction or stroke, are dramatically higher than people that don't have these lipoprotein defects. So even, like there's some people who don't believe in the cholesterol model, and that's silly because cholesterol is one of the variables that may have an impact in cardiovascular disease. But with these people that actually have genetic defects in increasing a variable that can impact the pathophysiology of atherosclerosis, you don't want to ignore that. So type 2s are a big concern here. Type 3s and 4s are a concern. Type 1 and type 5s, not really of major concern. So their numbers may look really bad, but if you really look at their risk over time, it's not really much greater than those that don't have these types of hyperlipoproteinemias. So again, these are the chart here. Let me show you a case example. So here you can see, for example, total cholesterol 274, LDL cholesterol 197. So obviously this is extremely high. This is elevated. So this would be your clue as a clinician to go, maybe they do have some kind of genetic defect in how they process lipoproteins. And this one, obviously, there's something happening with LDL. And even if you look at this person's lipoprotein particles, you can see their LDL particles are high, which we saw earlier. Their LDL cholesterol is high. It's in the 200 range when they tested again for this test. And they have lots of small particle LDLs. These are a big concern. And when you look at their actual phenotype, this is a type 2A. So type 2A is definitely an increased risk. With type 2As, you have this significantly high risk, and this is an LDL receptor defect. So what happens is, like for example, in this type 2A, the body's making LDL, the LDL receptors are not working, so the liver keeps making more LDL because it doesn't realize that there's enough of it in circulation. Now there's all these extra LDL levels that would have not been there if the LDL receptors worked. And now if these high LDLs are in there and there's any kind of oxidative stress or inflammation, then you get oxidized LDLs, and there's going to be a potential number of these LDLs that are going to be small LDLs, and you have significant risk for cardiovascular disease. So here, if you take a look at this, if you give him a statin drug, or even if you give them something like red yeast rice extract, you may not see these numbers change very much. That's another clue for you to really look at their lipid phenotype test. So be aware of that, because even though like you might take, let's say, a statin or red yeast rice extract, like a natural form statin, they're both HMG reductase inhibitors. So if you decrease HMG reductase and you impact the synthesis of cholesterol to some degree, but if the LDL receptors aren't working, like in this example, type 2B, you can have very, very high levels still produced, and it's going to have very little effects in making the change in LDL with any of those compounds, whether it's pharmaceutical or nutraceutical. So, this is where the rest of looking at cardiovascular risk factors, the LDL small or the LDLs oxidized, we can measure oxidized LDL. All the things we talked about in the cardiovascular course can be important. But the key clinical profile for this month, or for this module, is whenever you see cholesterol that doesn't respond, or you see an abnormally high total cholesterol, like here you can see the LDL very, very high, go ahead and order that lipid phenotype test, and then just read the classification if they have one. And then once you know that they have, for example, type 2, then you can refer to these charts and determine what their risk levels are. And then you can also look at what kind of defect is involved, right? So type 2 LDL receptor deficiency, not enough LDL receptors. Very important test. Will really help you understand some patients that are not responding, and also for some patients that are always high cholesterol and they just don't understand why, and they think it's just their diet causing it. It may not be their diet causing it. It just may be the fact that they have these defects, and somewhere in their lipoprotein synthesis, clearance, or at the receptor sites. Okay, I hope you find that useful. Thank you for your attention.